ناوي أطلع كمان. أنا ممكن نبدأ شوية.
مساء الخير.
مساء النور. ازيك يا دكتورة أمل؟
ازيك يا أمل؟
الحمد لله
أخبارك؟
تمام الحمد لله.
احنا البارتيسيبانتس دخلوا وي ار لايف دلوقتي. لايف على اليوتيوب.
طيب
نبدأ؟
ماشي.
نبدأ.
أنا انتوا شايفيني؟ انتوا
لا.
شايفيني؟ لا. طب أنا فين فاطمة؟ ازيك يا رشا؟ مش رشا؟
أهلا دكتورة مها، ازي حضرتك؟ أيوه مظبوط.
ازيك يا رشا؟ عمالة أنادي عليكي
الحمد
أهو.
لله. أنا أهو
شكلك
أنا
في
أهو
الكاميرا.
والله أنا أهو.
انت اهو، انت زي ما انت. طيب ماشي. دكتورة
طيب
صفيناز.
ماشي الحمد لله.
ماشي هخش. طيب أنا فين؟ أهو أنا أهو.
افتحي الكاميرا
اهي
بتاعتك.
أهو. أنا أهو ظهرت. أنا ظهرت كده ولا لسه مش شايفيني؟
لسه شايفين اسمك لكن صورتك لا.
طيب نرجع نرن على فاطمة، اتعذبت معانا الحقيقة. ايوه يا فاطمة انا دخلت. انا دلوقتي يعني مش عارفة افتح، بفتح الكاميرا. هم سامعيني لكن حد مش
ايوه
متشافة يعني.
سامعينكم انتوا الاثنين.
احنا فاتحين حوار، هي على التليفون وكل الأجهزة مفتوحة.
بالظبط.
اعمل ايه؟ بفتح الكاميرا. حاضر. نقفل المايك انت اهو. اهو.
ايوه كده ظهرتي. افتحي المايك بقى.
ضعيف مش شايفين في لا احنا معانا 28 27 في 27 اودينت معانا. ده غيرنا ولا بينا؟
لا بينا كل ده، كل البارتيسيبانت.
تمام. اسماء هتخش من دلوقتي ولا هتخش في دورها في الاخر؟
هي داخله، هي معانا من دلوقتي.
اوكي بس مش باينه.
احنا
دكتوره صفيناز
كله جاهز، ممكن نبدأ؟
ممكن.
تمام.
طيب تمام. هي الدكتورة ريما قالت لك هتدخل 6:30 بالظبط. يعني هي مش معانا دلوقتي ولا معانا؟
لسه هتجوين بس.
اظنها.
طيب ماشي ماشي ما هي عندها عيادة
She قالت she will join at her time because she has an appointment with the patient. Do you remember? عشان كده
أيوة.
بدلت هي وأسماء.
وأسماء. أوكي. طيب خلاص نبدأ بقى. طيب
تمام.
بسم الله الرحمن الرحيم. إن شاء الله يا رب يعني يبقى meeting useful. حد بيقول الصوت واضح. طيب إن شاء الله يعني نبدأ تاني ميتنج لسلسلة الويبينارز بتاعت إلكا في 2025. Our talk today or our webinar today is about complementary feeding. Some untackled aspects about complementary feeding, not the traditional aspects about introducing food and the art of introducing food, taking into consideration these untackled or sometimes confusing aspects of complementary foods. We will start with Dr. Safinaz Yusuf Salama. She's a consultant neonatologist and an IBCLC. And she's head of the scientific department of the Saudi Breastfeeding Association. تفضلي دكتورة صافيناز. Dr. Safinaz will tell us about the timing of food introduction, and if there is a debate, we'll see.
بداية first of all I'd like really to thank دكتورة أمل الطويل. She's أستاذتي الفاضلة طبعا. دكتورة أمل الطويل, it's really I'm grateful that you asked me to share in this invaluable webinar, at least to share and learn from such an expert speakers. Thank you very much to start with. As you asked to speak about the debate. أنا الأذان جنبي معلش. بس لسه شوي دحين وينتهي الأذان إن شاء الله جنبي بالضبط المسجد. طيب الحمد لله. So complementary feeding and the time to start, is there any debate? So let us proceed. As we all know that WHO and soon after that the UNICEF recommend exclusive breastfeeding, and that was since 2001. And actually, with the multi-center study held by the WHO after that, they find that really infants do grow on exclusive breastfeeding during the first 6 months, as we can see in this graph for girls and for boys, because of the invaluable content or component of breast milk, including essential fatty acids, proteins, immune factors. So infants do grow well on exclusive breastfeeding during that period. After that, many organizations and medical academies adopt that recommendation. And if we look at the American Academy of Pediatrics in 2012, they recommend exclusive breastfeeding for the first 6 months. But recently, the latest policy statement by the American Academy, they start to be a bit flexible. They mentioned exclusive breastfeeding about 6 months, and complementary solids should be introduced about 6 months for most infants, not because an expert panel under the same academy advised peanut introduction as early as 4 to 6 months, as peanut being one of the most common allergens in the States. So they advised to give peanuts from 4 to 6 months for infants who are at high risk for the allergy, but not to wait until after the 6 months for those who are on a moderate or low risk allergy. The Canadian Pediatric Society, also recommending complementary feeding to be started at 6 months, and that was as per the latest recommendation. And they also recommend to introduce common allergens early, around 6 months, not to be delayed, including eggs, peanuts, cow's milk, soy, wheat, fish. And early introduction, as per the recommendation, may reduce the risk of food allergy. And we're going to hear more about allergens from more expert speakers. And currently, the infant Canadian feeding guidelines are under revision. So maybe we're going to hear more detailed recommendations. If we look at other parts of the world, including our great countries, also other part of the world, Brazil, South Africa, on the West, China, India, Australia. As far as Australia, they all align with the global recommendation of WHO and UNICEF. How about Europe? It's begun. Europe, they have different opinions. As per the recommendation, as per the latest guidelines from the ISPGAN website on complementary feeding, which was published in the Gastroenterology Pediatric Nutrition Journal, they say that gastrointestinal and renal functions are sufficiently mature by approximately 4 months to enable the infant, the term infant, to process the complementary food. And by 4 to 6 months, infants will have attained the necessary motor skills to cope safely with complementary foods. That is their opinion. So, and for them, describe the developmental readiness, being that the infant has the ability to sit with support, has a strong head and neck control, and they show interest in food, for example, reaching for food, watching others also eating, and they have decreased at the same time the tongue thirst reflex, so they can take the food into their mouth, not to push it forward, which helps the baby to stick the food and swallow. And also, part of the development being able to coordinate eye, hand, mouth contact. So, if began guidelines, and that was the latest by 17, they suggest introducing complementary feeding depending on infants' developmental readiness and nutrition needs rather than a fixed age. So, and they recommend exclusive, what the recommendation says, the exclusive breastfeeding should be promoted for at least 4 months or 17 weeks and the beginning of the fifth month, and exclusive or predominant breastfeeding for approximately 6 months is considered a desirable goal. So it's not a clear fixed to 6 months. So several European countries, including Germany, Sweden, Denmark, Netherlands, Finland, and Belgium, they align with both WHO and ISPGAN. How? Because they support exclusive breastfeeding for first 6 months as WHO recommendation, and at the same time they allow complementary feeding between 4 and 6 months based on infants' development signs. How about it's not the same case in UK? In UK, the National Health Services recommend exclusive breastfeeding for first 6 months, with starting the complementary food at 6 months of age. They do not support earlier introduction, for example, 4 months, unless advised by healthcare professional for a specific reason. So they're not the same as other European countries. So everybody agrees that we should not delay complementary food after 6 months of age, because the infant already now in need of more energy and more nutrients, especially macronutrients, which now the infant's need exceed what's provided by breast milk. But no delay, so no delay be after 6 months. But the debate is, why not before 6 months? If you look at some of the studies which go through this issue, starting with this study which was published in 2016, the impact of early versus late complementary feeding on infant growth, comparing starting 4 months versus 6 months. The finding was introducing solids at 4 months was not associated with improved growth compared to 6 months. And so early introduction did not offer significant growth benefits. The other study, which was a bit earlier, looking for the early complementary feeding and the effect on long-term health, of the child. That was published in the International Journal of Pediatrics. It was an RCT, or randomized controlled trial, examining the long-term benefit and outcome of exclusive breastfeeding until 6 months, with focus on growth and immunological health. The finding was infants who were exclusively breastfed for 6 months, they have better health outcome, including they have lower rate of obesity, lower incidence of type 1 diabetes. They have less risk of developing or having respiratory infections compared to those started earlier. The other study, which is a really a large study, detailed study, it was on the optimal timing of introduction of complementary feeding, systematic review and meta-analysis by 21, and this is one of the main references of even the WHO guidelines published 2023. The data reviewed 240 studies in total. None of them were randomized control trials. From 26 papers, they chose 9 studies and 2014 observational studies. And they choose 80 of them and 7 RTTs. Total of really nearly 4,000 participants were included in the meta-analysis of infants. They found for the optimal time, they were looking at the optimal time of introduction. So they compared early introduction, which is less than 6 months, as compared to earlier. In normal, they looked at different, comparison states. But here I will concentrate on before 6 months or 6 months and after. And I will concentrate on full term because they looked even at small for gestation age infants. Their primary outcomes, anemia, child developmental measures, even cognitive and socio-behavioral or motor development, food preferences and food allergies, and the non-communicable diseases, including glucose intolerance, hypertension, cardiac diseases, inflammatory or autoimmune diseases, cancers even, and infants and child mortality. Secondary outcomes include hemoglobin level, micronutrient status, including serum level of iron, serum ferritin, vitamin A, zinc, folic acid, B12, and fatty acids also. The secondary outcome, waist circumference and skin fold thickness, gut health and microbiome, bone mineral density, bone mineral content. So, the summary of evidence of this large study, which was held or published 2021, was if you look at full-term infants, early complementary feeding, which means before 6 months of age, was linked to increased body mass index, overweight, and obesity. So obesity is really a disease. And if we look at the full-term infants, less than who start complementary food before 4 months of age, they have increased not only body mass index, not only the body mass index Z-score, overweight, obesity, but also they are at risk of have stunting of growth, higher blood pressure, either diastolic and systolic, lower respiratory tract infection more, and more to develop anemia. How about preterm infants? That study also studied small for gestation age infants, but I choose to also, because of time, to show this study, which was published in 2017, looking at the complementary feeding at 4 versus 6 months of age for preterm infants born at less than 34 weeks of gestation. It was a randomized open-label multi-center trial. That trial was including 206 infants start to be fed by 4 months, and the other group, nearly 200 fed at 6 months of age. Sample collected between March 2013 and April 2015. Infants who they have no major malformations and were randomly assigned. Both groups have similar weight for age Z-scores and other growth outcomes. They have also similar body composition, bone mineralization status. They have same iron stores with also at the same time they are receiving iron supplements, but they checked at 12 months of age. So they have same, as I mentioned, weight for age score and growth outcome. Also, motor and mental development were similar in both groups. And again, this is the reference. No difference in weight for age Z-score between two groups. And also, the two groups, which one of them start feeding below 4 months, and one at 6 months. But if we look at this group on left side, who started feeding at less than 4 months or equal to 4 months, they show higher risk of hospital admission, more episodes of diarrhea, infections of lower respiratory tract until 12 months of corrected age. On the right side, the story is better because they are at risk of, they have less risk of hospital admission by 48% compared with the other group. These findings suggest that initiation of complementary feeding at 6 month corrected age might be better in comparison to 4 month corrected age in infants born at less than 34 gestation age. So now we come to the WHO recent guidelines, which was published in 2000. Next, Dr. Fatma, which was published in 2023. That guidelines for complementary feeding reinforce again widely accepted practice of exclusive breastfeeding for first 6 months of life and introduction of food by 6 months of age. Gradually, it is detailed. It is made up of 7 recommendations, and these guidelines based on strong evidence, including randomized controlled trials, systematic reviews, and meta-analysis demonstrating the benefits of exclusive breastfeeding in reducing risk of infections, supporting optimal growth, development, and enhancing, of course, infant immunity. The guidelines also, as I mentioned, made up of 7 recommendations, but we are here because in my talk, I'll concentrate on number 3, which says age of introduction of complementary food should be at the age of completed 6 months or 180 days while continuing to breastfeed. Infants, I mentioned just the النص حقها. So optimal timing of introduction of complementary feeding in the new guidelines of WHO published 2023 is still at the age of 6 months with exclusive breastfeeding before that. And I mentioned that the study I just saw before for a few slides was systematic review and meta-analysis was one of the major reference for that recommendation. So, is there any debate after that? I think next one, Doctora. Next slide, please. So the slide is showing the 7 recommendations, but in my talk, I'm going to concentrate on number 3, which is about the age of introduction, which is 180 completed days, and exclusive breastfeeding before that. So, still, is anybody do anybody agree with that recommendation? No, there was a response around. It was in the same around maybe published less than a year later. The recommendation came at 2003, and this response came 2024. This screen is from the SPGAN website, and this response was published in 2014 in the Journal of Pediatric Gastroenterology and Nutrition. It was not only by the SPGAN. This response was multi-society response, not only by the European Society, SPGAN, but also from other areas. European Academy of Pediatric, European Society of Pediatric Research, European Academy of Allergy and Clinical Immunology, even Pan-Arab Society for Pediatric Gastroenterology and Nutrition. Also World Allergy Organization, North American Society, Asian Pan-Pacific Society, and Asia Pacific Academy of Pediatric Allergy and Respiratory Immunology. So, what was the point, or what was the point of divergence? فين كانت أوجه الاختلاف? If we start their comment on the process, there is lack of as they say in the response. There is lack of stakeholder involvement and consultation in developing the process in developing the guideline. The process used to obtain consensus by the guideline development group is not clearly described. For example, it's not clear how many of the group agreed with each recommendation. Still in the divergence on the process, they also note that systematic reviews considered evidence up to end of 2020 and early 21. And the question was why there is no update before the publication. Maybe just a 1 year gap. Uh, the divergence on the infant factor include the recommendation considered nutritional aspect of complementary feeding but omitted highly relevant factor, which is the infant's developmental readiness. To explain that, they mentioned that the one comment on developmental readiness in the guideline is not based on evidence, which is the ability to sit without support. But their comment is that ability to sit without support is important, yes, for the infant to consume finger foods, but not for consuming purees or mashed foods. Infant who can sit with support, he can tolerate purees or mashed food. The authors also were arguing the link between the maturity of the gut or kidneys, which can handle non-liquid foods from very early in the postnatal period, and the infant's neurodevelopmental readiness. If we move now to divergence, which is regarding the allergens, they noticed that the guideline does not address the appropriate age for the introduction of allergenic foods. And these are some of the most common allergenic foods. They mentioned that high quality, or they also include these studies or references in their response. High quality evidence from several randomized controlled trials demonstrates that early introduction of allergenic complementary foods before the age of 6 months, along with continuing breastfeeding, can markedly reduce the risk of food allergies. We have more experts than me to speak in that field, so I'll just move. And also, they mentioned that the recent European evidence-based guidelines on allergy prevention concluded that the most effective time window to induce the allergens is 4 to 6 months. Yeah, 2 slides later. Yeah. So they suggest what they suggest or what they recommend after they publish that response. Yeah, now we are here. So they recommend in that multi-society response, exclusive or full breastfeeding should be promoted for at least 4 months. Again, 17 weeks, beginning of the 5th month, and exclusive or predominant breastfeeding for approximately 6 months is considered a desirable goal. It's not a must, a desirable goal. In populations affected by food allergy, or maybe some who has strong family history, complementary foods with high allergenic potential, for example, well-cooked eggs or peanuts, may be introduced in an age-appropriate form when complementary food is commenced anytime from 4 months. So that was the response to the WHO guidelines, and it was published, as I mentioned, in the Journal of Pediatric and Gastroenterology Nutrition journal in 2024. And I found also another next one, a more recent study looking at the timing of complementary feeding and infant growth in prospective cohort studies, published recently in 2025, and in the Ecology of Food and Nutrition. Thus, systematized review and analysis of socio-ecological variation. They studied 22 studies who met the criteria, because they collect more than that, but only 22 of them met the inclusion criteria. So they were conducted between 1987 and 2017, but when they finished and published it was 2025. The majority of reviewed studies used cohort or observational designs. 5 studies were randomized controlled trials. What they noticed they mentioned in that study: early complementary food, we mean by early here, before 6 months, was not consistently associated with growth differences in infants, even in randomized controlled trials. There is no strong evidence that early feeding leads to either faster or slower growth on average. The growth outcomes vary widely on the socio-ecological factors, depends on cultural feeding norms, caregiver perception for infant hunger and growth, economic setting, and health infrastructure. So the conclusion of that recent study, infant growth outcomes are influenced by broader socioeconomic and cultural factors. In some society, the feeding the food or high quality food or high energetic food is available, while in others not available. Not only just the timing. So debate will still, I think, will continue, and we need further and further follow-up and studies. But and hope one day the picture will be complete, hoping for guidelines, united guidelines, looking for a healthy infants. And even if we don't agree with someone, we still accept their opinion and start looking further and further, hoping for uniform guidelines. So that was just a picture from my city, Jeddah. And if you, these are my references. I tried to make it short, and if you are interested in the references, you will find it here in this barcode.
Thank you very much, Dr. Safinez. That was really a very informative talk, and very recent also references. And as you said, the debate continues. The more recent reference you bring, the more the hope increases that the debate settles down, but it even raises more debate.
Yeah.
Thank
you very much, Dr. Amal. Thank you very much.
You're most welcome. Dr. Rasha Gamal, Professor of Pediatric Gastroenterology and Head of Department of Pediatric Gastroenterology in Tanta School of Medicine. She's going to tell us about what to introduce and if there are special situations that we need to consider. تفضلي يا دكتورة رشا.
I'm really honored to be with you today. Thanks, Dr. Amal, for this opportunity. My mission is difficult today in this limited time, but I will try. My mission is about complementary feeding, what to introduce and what are the special situations. As by definition, complementary feeding means introduction of nutrient and energy containing solid or semi-solid foods to the infant with continuation of breastfeeding. And at this point, many questions need to be answered, like when, what, and how. My mission today is to try to clarify the answer to the question what, and this depends really on many factors, including nutrition requirements, feeding skills, and what is optimum according to the VATPA principles and WHO recommendations. Starting with the nutrition requirements, as we know, starting from the 6 months, a rising nutritional gap regarding energy requirements appear in spite of maximum efficient breastfeeding in these stages. And this nutritional gap can not only about energy, but also rise regarding protein, iron, zinc, calcium, and vitamin E. And these nutritional gaps can be fulfilled through the timely introduction of appropriate complementary foods at 6 months according to the WHO recommendations lastly updated in 2023. This requires acquiring certain developmental skills in order to open the critical window of introducing lumpy food with a wide variety of tastes and texture in the first months of life, in order to lower the risk of developing later feeding problems and food allergies. The achievement of these developmental steps is required for transition from a liquid to pureed diet to and later to the solid food, and this includes a change from reflexive feeding to voluntary independent feeding. by the disappearance of protective reflexes like tongue thrust reflex that protect against shocking and aspiration, but the protection is still provided through the gag reflex during the first year of life that helps the infant to control the food in their mouth, and it shouldn't be intervened. Feeding skills involve the maturation in many fields, including oral, gross motor, as well as fine motor skills according to the age of the baby. But remember, each child is different and have his own developmental pace. And these developmental skills are affected by the experiences provided by the caregiver. So there is wide variability in the norm. Regarding the taste preferences, generally speaking, there is innate preference for sweet tasting food that diminish over time, but actually the story starts early in utero and postnatal through exposures to a wide variety of flavors that affect the infant subsequent acceptance of these flavors in the food. Now, what is optimum according to the VATFA principles and WHO recommendations? This includes the frequency of feeding, amount of food, thickness of food, variety of food, active or responsive feeding, and hygiene. Starting with the frequency and amount of food, the previously mentioned nutritional gaps are covered by appropriate amounts, meal frequency, and texture according to the age. For those aged from 6 to 8 months, they receive pureed or mashed food in 2 to 3 meals, each starting by 2 to 3 tablespoons and gradually increasing to half a cup. And those aging 9 to 11 months receive mashed or finger food in 3 to 4 meals, each half a cup. And by the end of the first year, it's okay about family foods in 3 to 4 meals, each 3/4 of a cup. And additionally, may add 1 to 2 snacks to be offered according to the child's appetite. Always remember, parents are responsible for what and when, but the baby is responsible for how much according to his or her stomach capacity. Second, there will be the thickness of food. As we are replacing the breast milk, the food should be thicker and stick to the spoon to provide more energy and nutrient density to be appropriate, with gradually increasing the food consistency and variety as the child ages till the transition to family food at the end of the first year. And don't forget to introduce finger foods at the age of about 8 to 9 months when the pincer grasp is well developed. Regarding the variety of food, according to the latest updates in the WHO recommendation 2023, a child should receive a diverse diet, including breast milk and additional 7K food groups. And a minimum dietary diversity is achieved with the consumption of 5 of the 8 groups. No evidence or benefit to introduce complementary food in any specific sequence or any specific rate, but stick to the rule of 3 for introducing each single food, and after tolerance is established, combinations can be given. And as healthy habits starts early, high sugar, high salt, high trans fat food shouldn't be consumed together with beverage and non-sugary sweetener, with limitation of fruit juice consumption. Water to be added with complementary food about 4 hours per day, but not before that, as breast milk is mostly water, while non-breastfed infants usually need extra water. Regarding fruit juice, it is never to be offered before 6 months, and the American Academy of Pediatrics recommend not before 1 year. Must be 100 unsweetened using open cup, maximum 4 hours per day. Leave it to the end of the meal, as too much juice can cause tooth decay, diarrhea, and relate to faltering growth. Regarding responsive feeding, the child signals hunger and satiety, and the caregiver recognizes these cues and responds promptly in a manner that is emotionally supportive and developmentally appropriate. So parents have to learn to trust and respect the baby's signs of hunger and fullness. because behavioral experience suggests that breastfed infants can regulate energy intake as early as the first week of life. The last item is about the hygienic practices. It should be integrated across all elements of complementary feeding regarding using treated water, clean utensils and bowls, and proper hand washing for the feeder and the infant. So, let's know how to deal with some common situations regarding complementary feeding. If the mother is saying, my baby isn't eating because he doesn't have any teeth, the response will be that babies are able to eat a wide variety of food without teeth through munching. Munching is chewing without teeth. Another mom, I will give my baby a mobile or switch on cartoons on TV while feeding. The response is advice is don't resort to distraction feeding. The time for feeding it should be about food only and nothing else. Another mom coming, my baby doesn't like the food right away or seems startled by the texture. I will stop it. The advice is don't give up. Offer that food another time, and he may need up to 20 or 30 times of exposure to enjoy this food. A mom says, I just started solid food. Why my baby is refusing the spoon like that in the picture? As actually, this baby is having a tongue thrust reflex persisting till now, and he is not ready yet. So I will advise her to wait 1 to 2 weeks and try again. This baby is refusing food, and the mom wants to force him to eat. No, never to make it. It make it worse. You must honor the cues of refusing feeding in your baby and don't give up offering that another time again. This one is trying to hold the spoon and the mother is trying to hold his hands down to avoid the mess. No, you actually never to have to do this. It's a fantastic developmental step and should be celebrated because he is trying to self-feed himself. Another mother is worrying about fat or in the diet of her baby. She thought it is unhealthy to give fat to her baby. No, fat is important nutrient for babies and their brain growth, so give him fat in his diet according to the recommendations. This baby is the mother is worried. He's gagging the whole food, and I will give him puree food to be safer. No, this baby is having a gag, and the gag is not a life-threatening. It's a protective reflex, helping them to deal with the food in their mouth. You please don't scare the baby, or he may develop food resistance later on. These are some of the common situations. Let us deal with. Are there special situations? I think we all agree that one of the most common complaints in our pediatric clinics is my child doesn't eat. And when there is a problem negatively affecting the process of providing food to the child by the parents, it means there is a feeding difficulty or feeding problem. This term comprises various levels of severity. When a parent is coming to you with his child suffering from his poorly eating, some of them is misinterpreting his child. Most of these children have a mild affection, and this very small percentage is having actually a serious feeding disorder. And the feeding problems are estimated in about 20 up to 50% of typically developing children, in about 80% of those with developmental disabilities, and in 85% of those with complex medical conditions. As we have said, it's a wide range of possibilities with severities. We have to differentiate between those with feeding difficulties and those with actual feeding disorders. Feeding difficulties are resolved with time, doesn't affect the growth or nutrition, and doesn't require any interventions other than reassurance of the parents. While feeding disorders are related to dysfunction and usually associated with significant growth and nutritional problems, and usually persist because the underlying condition is persisting with us and need a multidisciplinary team to deal with it. Some of the presenting features of feeding difficulties that we may see: prolonged meal time, prolonged food refusal, stressful meal time, lack of independent self-feeding, distraction to increase intake, prolonged breastfeeding, and failure to advance in textures. Now rises the question, when I should refer to a specialist. Referral to a specialist will be after ruling out the red flags, and red flags may be organic or behavioral like in this. Some of them are dysphagia, shocking aspiration with recurrent pneumonia, pain and excessive crying with feeding, vomiting and diarrhea, developmental delay, cardiorespiratory symptoms, growth failure, among others. Or simply use a simpler tool to identify infants at risk and refer them to the required specialists. After excluding the red flags, we are confronting three major categories of feeding problems according to the parental concerns. Some of the babies are with limited appetite or not eating enough, some others with selective intake or eating inadequate variety of food, and others are having a fear of feeding or afraid to eat. And in order to understand the principles of management and some details about these, we are going to dive into some case scenarios. Here we have a baby called Habiba. She is 7 months old. She has a normal health history with no problems or latching during breastfeeding. But when she is given pureed food, she go make gagging sound and spit out food sometimes, while maintaining her growth parameters on the 50th centile, which is good by chance. Um, but the mother is having concern about her child growth and stress during mealtime. Developmentally, she is meeting the appropriate milestones for her age, and the gagging on eating pureed food will improve with gradual increased exposure to food, to solid food, and by doing this in a calm and a positive environment. So, in this condition, we just reassure the mother there is nothing wrong and there is no further investigation required in case of Habiba. So when are confronting a feeding complaint or difficulty in an infant who is growing and developing normally without red flags, we just reassure the patient, equip them with the knowledge, and revise with them the basic food rules that apply to all infants and children. We have to remind them that baby is responsible for how much. We have to respect the feeding cues of her baby. We have to make eye contact and remain interactive with the baby during feeding, and never to force or make criticism to the child while eating. There are some strategies for these common parental concerns when the case is mild without being severe or serious disorder. In case of limited appetite, we can fortify the food